like to welcome everybody to today's webinar, Optimizing Prediabetes and Screening by Using Your EHR. Our presenters today will be Ms. Karen Bishop, who is the Manager of CliniSync HIE Connectivity and Exchange Solutions, Mr. Rich Branch, who is a CliniSync Community Project Manager, Ms. Cathy Costello, who is the Director of CliniSync Plus Services, and me, Mr. Scott Mash, which I'll just be handling introductions for today. And with that, I'm going to turn it over to Ms. Cathy Costello.
Good morning, everyone. Thanks so much for joining us. I'm so glad we had good weather. Keep everyone attentive today and hopefully enjoy the day. But what we wanted to cover today, we had covered the hypertension area a few weeks ago. Now we're looking at diabetes, but not diabetes as the person identified as having diabetes, but for people identified in that pre-diabetic stage where you want to track them and make sure they're receiving appropriate care, but they have not gone all the way to be considered a diabetic. So it's really important to understand how to both manage these patients, how to bill for them, how to do referrals for them, especially into this new diabetes prevention program, which we will talk about. We're very fortunate to have Karen Bishop with us, who actually had several years ago constructed the first what we call medical neighborhood tool, which is the referral tool for quite a few different social service agencies in this area. And she's going to talk, after we talk generally about prediabetes and how to work with the coding and the diagnosis of it, she's going to show how the referral tool can be used to manage your patients generally. And then at the end, we're going to have Rich Branch, who actually is the field rep who was working with both of our two FQHC sites in northwestern Ohio, and has actually constructed the diabetes prevention program referral tool customized to their needs in sending a patient from the FQHC site to the hospital diabetes prevention program that is run in their community. So with that, why don't we look and see, first of all, what exactly we're talking about when we talk about prediabetes. I think people get confused when we talk about prediabetes, because they're thinking, well, yes, we understand having diabetes, we understand the need to monitor that, but what exactly is prediabetes? And prediabetes is very simply when a patient's blood sugar is high, but has not reached the level where it's considered to be the patient is not considered to be a true diabetic. And so the reason this becomes so important, and the CDC has spent just enormous amount of effort on this program the past few years, is to try to prevent patients from becoming true diabetics, and we'll show you exactly why this is effective. In fact, I have to say, of all the information we get from the federal level, this to me was actually one of the most surprising areas. It's like a simple self-help area that can make a huge difference both to the patient and to your community when you're working with diabetics. First of all, CDC estimates right now that 86 million Americans have prediabetes. So over a third of the overall population in the United States have prediabetes, and over half of the patients who are 65 and older have prediabetes. So it's not a small segment of the society, as we can tell. And the interesting thing is, it shows absolutely no preference as far as ethnicity. In all ethnic groups, you see pretty much the same percentage, between 35 and 40% of your adult population is pre-diabetic. In Ohio, this figure mimics the national figures, And I think we know from our work, all of us in diabetes, that we have over 10% or over 1 million patients in Ohio with diabetes. But I don't think we did recognize how many more have prediabetes. We have over 3 million people, in Ohio. 35% of our adult population have prediabetes. So this is really absolutely something you want to move into your workflow, make sure that you're addressing it, and have a very smooth process to transfer the care of these patients into a prediabetes program once you have identified them. Obviously, you want to continue to follow up yourselves, but you also want to make sure that they get into these programs. And we'll talk about what constitutes those programs in just a minute. Let's talk first of all, what tests? So clinically speaking, what do you need to do to identify that patient as pre-diabetic, which is then going to qualify them to move into one of these programs? The most common, 4 most common tests, I don't think anyone would be surprised at these, are your fasting glucose, your non-fasting, your 2-hour GTT, and your A1Cs. So as you can see from the figures in the right-hand column, in each case, the patient's glucose level, however it is run, whichever one of these tests, you're looking at figures, your results are slightly above normal, not slightly, but in the category between normal and what we would consider to be diabetic. And I would say the one that we see used most often when you're setting up a referral into a DPP program is the A1C as the required test. But as far as Medicare and your insurance companies and what they would ask as far as identifying who is a pre-diabetic, I think any one of these tests where it falls above the normal range but not so high as to be diabetic can be tracked as pre-diabetes. The reason this is important, and this is, as I said, I feel like both Scott and I have become real preachers in this area in the past year because we've just been so amazed at the statistics around prediabetes. Because not only do we have such a high population with prediabetes, but the reality is you can actually do something about it. Unlike so many chronic diseases where you think, what can you do other than manage the symptoms? With prediabetes, if you can intervene and take action and get these people into a diabetes prevention program, then you actually have a shot at preventing them from becoming a true diabetic. Because it is estimated, and this is based upon actual clinical data, that every year 5 to 10% of people, if there's no intervention, 5 to 10% of people who are identified as pre-diabetic will go on to develop type 2 diabetes. So within a 10-year spread, virtually everyone that you have identified as pre-diabetic, if nothing else is done, will move on to become a type 2 diabetic. So, and you can track this by what the, looking at the development over the next 30 years to show that they believe that the rate of diabetes in this country, this is CMS's prediction and CDC, that the rate of diabetes in this country will double if there is nothing else done. So I have to say that this is really significant work that you'll be doing if you set it up at the local level in your own specific sites. If you look at the last statistic on this page, this is why it is so important. Because they have shown, this is actual studies, and this is why I think it is so amazing. They have shown that patients who have gone through the Diabetes Prevention Program that was established by the CDC. If they complete the program, they can prevent the onset of diabetes in almost 60% of the cases. So 60% of the patients that go through this are prevented from becoming type 2 diabetics. Well, you can imagine what CMS is thinking. What chronic condition, except possibly hypertension, but I think diabetes is actually a more expensive driver of chronic conditions in the United States, even than hypertension. And so one of the things that we saw in the regs, and we're going to look at just a second. Let me see if it's on this next slide. No, I'll come back to it in a second. But in the regulations that were passed last year, there was a whole long section about diabetes prevention programs and how CMS was going to fund it, and they were just so excited about it. Because the statistics were so in favor of working with pre-diabetics, they actually stopped the studies early, and the Congressional Budget Office, which we know doesn't often approve stuff lightly, said that the figures were so compelling that there was every reason to support the development of a Medicare diabetes prevention program. However, the reality is, as we all know, there's a lot of moves afoot at the national level to kind of roll back the regulatory area. And so we have not seen whether CMS is going to be able to add a Medicare DPP next year, but we will know that within the next 3 weeks that reg is supposed to be out. If that is the case, we obviously will share that with you. I think it's really important that you understand if Medicare is going to stay in this area as a program, an adjunct to the current CDC DPP program. And don't get me wrong, even if Medicare would not pay for it, the CDC DPP programs are going to continue in existence, and if nothing except gain more notoriety for the fact that they are able to handle patients in this area. So again, just to be clear, there are proposed regs in this area. We just don't know how they're going to be finalized for the Medicare population, but that should not stop you from working with the DPP programs as they exist now, which can include your Medicare patients. It's just a question of who pays for it. Okay, so one of the things that the American Diabetes Association has done, which I think is quite helpful, is they put together the information that you all would normally ask a patient anyway as part of a patient intake, but it draws it together into a self-assessment form as to that scores the patient from a scale of 0 to 10 as to whether or not they are at risk of developing diabetes. And so it makes it easy. It's something that the patient can do, that you can give to the patient, and they can score it, and then you can put it in their chart, or you can have someone in the office ask the same questions and enter that directly into the chart. And just to keep in mind, the patients that are targeted in this ADA form is if the patient is 45 or older, you should probably be doing this on every single patient because the risk of developing prediabetes is so high, as we saw, over 35% of the population. If they're 45 years or younger, and they have identified risk factors, which we will look at, then you're probably going to want to go ahead and have them fill it out anyway. So here is the link to this diabetes risk assessment, and you can either download the paper version, or you can actually have them complete it online. And it's a very simple, it moves very quickly. We just took it this morning again to, double check it to see what it has. The one thing I'll say, if you use the download version, that if you do the online version, when you get to the last step, it allows you to print out the patient's score, but unfortunately it doesn't give the answers to all the questions. So even though you know how they're scored, you're not going to know whether the score was related to their BMI or their family history or whatever. So just a word of caution when you use it, which is probably just as well if you enter it directly into your clinical EHR system. So here is the actual ADA risk assessment form. And as I said, very simple. Your patient shouldn't have a problem filling it out. The first area is how old are you? What is your sex? If you're a woman, have you had gestational diabetes? Do you have a family history of diabetes? Have you ever been diagnosed with high blood pressure? This is a risk factor for diabetes also. Are you physically active? And what is your weight? So very simple. The whole thing should take no more than just a few minutes. And the online version will actually go ahead and then calculate the score automatically and tell you whether or not you fall into that risk category. But if you do this and the person shows up to be 5 or above, then they're considered high risk, or at risk, I shouldn't say high risk, but at risk, and that's when you want to get into more diagnostic information about should you run lab tests on them and stuff. And so what we're going to do now is look at the coding related to the prediabetes area. So if you run the prediabetes screen, or you have the patient take it, and you see that they fall into this at-risk category, what do you do about it? Well, there's several things that you want to do. First of all, you want to make sure that you enter an interim diagnosis code of R7303, and this will indicate within your system that this patient had elevated blood glucose but is not high enough to be considered diabetic. The reason this is important, and as we've worked with you for the past several months, that this is a key element, is to be able to draw information back out of your system about patients that you want to do ongoing tracking. And certainly people that are at risk of being pre-diabetic are one of your big target populations. So make sure at that time that you code R7303 if they're falling into this pre-diabetic area. As part of this, because this will go into both the payment and then how frequently you run the test, you want to also code in what basically are the same information that is in the diabetes assessment. So you want to make sure you have the age, the sex. If the BMI is greater than 25, you code that at Z68.25 or higher. You want the family history of diabetes coded, and make sure you have the history of high blood pressure. And as we talked about, there's like 8 or 9 different codes for blood pressure. So it's maybe that there is a specific code related to what you're doing, but there also may just be the fact that you recognize that the person has an elevated blood pressure reading but is not considered, does not have a diagnosis of hypertension, so you'd put in an R03 code. So these are all various things that you can look at to make sure that you're coding correctly. Also code in their physical activity and their history of gestational diabetes. So as you can see, if you put all these codes in at the time that you have one of these patients come in that you suspect is having prediabetes, it will allow you then to both code correctly but also to go back and pull the information so you can track those patients. So what do? Now you've got that information coded. You want to go ahead and run a glucose or an A1C. and to check on their status to see whether they're truly prediabetes. Well, how you code for that depends on whether or not they have how many of these risk factors that they have that we just looked at. So here is a chart, an easy chart to decide how to code for the work that is being done in the lab. So you start with the Z13.1, and whether or not you use what's called the TS modifier depends on whether or not they have the risk factors that would identify them as, you know, that you are trying to actually get a diagnosis as to whether or not they're pre-diabetic. So it just kind of alerts everyone in the system that you have a patient here who is considered at risk, that you're trying to confirm if they're true pre-diabetic. And part of what you're trying to do is to determine when you can take next steps and go back and check on that patient again if you're not sure where they fall with prediabetes or diabetes. So the first set of conditions that you want to be looking at is, does the patient have hypertension? This is in the middle box on the top. Does the patient have a BMI over 30? Does the patient have dyslipidemia? Or does the patient have a previously elevated glucose? So these are ones that would trigger, any one of those would trigger the use of the TS modifier. So this goes then on your coding for your lab. You put the TS modifier if any one of these conditions exists. If that is the case, then Medicare will pay for the testing without any copay or deductible, and Medicare will allow you to repeat it every 6 months. So it's important that you try to get that coded correctly. The second set of risk conditions, risk factors that we looked at in that middle box requires you to have 2. So the top set is that there's a very high risk, is the way I would interpret this. Very high risk that they are going to be pre-diabetic. So it only requires one of those conditions to be present. The middle box requires 2 because they are risk factors that have been identified, but it may be not as immediate as the top set of conditions. So in this middle section, you are also going to use the TS modifier, but in those cases where 2 of the conditions show up. So there's a family history, the patient is over 65, BMI is at least 25, but up to 30, and patient had gestational diabetes. So if any 2 of those show up, you also would code that as a TS modifier when you order the lab test. And then you do not want to use the TS modifier if the patient has never been screened for diabetes, or if they have been screened for diabetes and the test results show the patient is not pre-diabetic. So those are cases in which you just want to make sure you're using the TS modifier correctly. The things that you want to look at here is, as we've talked about, the use of the EHR to effectively monitor these patients, and that's why we want to get that coding in at the time that you first see the patient, because then that allows you to go back and identify as the lab test comes back whether they are truly pre-diabetic, but it also allows you to create a registry of kind of a watch list of patients that you're going to want to either call back in and see, or when they come back in, make sure that you again run your glucose to check as how they are. So these are all things that you can build in, as I said, into your workflow. I think it'll be much more successful management of your pre-diabetic population. The last thing, and this will be a segue into Karen and Rich's area, if you find that you have a patient who, when that lab test comes back, because at this point in time, most programs, if not all programs, with the DPP indicator, meaning that it's CDC accredited program, is requires you to have that glucose test, the A1C, that shows that it's elevated. So you want to make sure that when that test comes back, that you know what your next step is. So let's say you get a patient in with like a 7% on your A1C. What you want to do then is to make sure that you're referring them to the local DPP program, whether it's one that you yourself run or whether it's one that is run elsewhere in the community. There are at least 30 DPP programs around the state. And in your two areas, I know that in the one, you have the hospital running the program, and in the Lyman surrounding areas, you're actually considering setting this up and going with it yourself. So either way, it doesn't matter, but you want to get patients into this program. The scope of the program is basically to do behavior modification. I mean, really, it's stuff, it seems so simple, but it can make such a difference. So they're going to do nutritional counseling, they're going to do, have them exercise, do, basically lifestyle changes. And the goal of the DPP program is to have the patient lose at least 5% of their body weight. That is considered to be a successful monitoring for the DPP program. And these are the patients that once they complete the DPP program, it isn't that you're not going to see them again. It's obviously the role of primary care to go ahead and make sure that these patients are continuing to be monitored, which is why we talked about building it into your EHR. So the DPP program is in addition to your work as a clinician to make sure that you are adequately monitoring these patients. But by pushing them to a DPP program, there's already established education pieces that CDC has approved. There's already established nutritional information and exercise information, all of which can be used, and you will have, it's not something that you would have to create yourself. So we want to make sure, and as I said, that last bullet point is if Medicare does in fact go ahead with this next round of regs and approve that they're going to start paying first dollar for the DPP program for their Medicare patients, we obviously will let you know that right away. I think that's important to know. And they also had intended to put out an actual fee schedule for people who are setting up their own DPP programs. And again, both of those are things that you would want to know, and we will let you know. But with that, I'm going to turn it over now to Karen. So Karen can talk in a general sense about how these referrals are created, how the monitoring can go if you have a site that you want to make a referral partner to you, and you have specialized information that needs to go along with that referral, how it's all customized. So I'll turn that over to Karen, and then Rich will look specifically at the DPP referral. Karen, can you hear me?
I can. Thank you, Kathy.
Okay. Just tell me when you want to advance the slides.
Okay, will do. So basically I wanted to start talking just a little bit about the Medical Neighborhood Referral Infrastructure Project within Central Ohio. So that was spearheaded by the Healthcare Collaborative of Greater Columbus, where there were multiple organizations, both healthcare and social services, who wanted to come together in a joint way and exchange referrals. So that way they could take much more care of the patient from all angles and pull in the social services when needs arose. So what they decided to do was to leverage our hosted referrals program that is within our community health record. So that's what we're going to focus on, but I just did want to start with that. So next slide, please. So in this picture, basically within our referral system, we call it closed loop. because the referring provider will be able to watch their referral through the process when it goes to the recipient of the referral, the acceptance process, scheduling, all the way to adding notes perhaps to that particular referral until it is closed. Next slide. So within the referral process, basically, and we're going to kind of show you this in some other slides, but basically you begin by searching for your patient. If for some reason your patient had not been to any other organization that is currently participating with CliniSync, you actually would have the ability to load that patient within the community health record. Then you'll be able to begin the referral process for the patient and select the origin of that referral. One thing to note with when sending out your referral, each referral partner, so when you decide to be a referral partner through the onboarding process, what we'll do is we'll help you set up your customized questions so that way you can collect all the information you need from a referring provider or organization. So, you know, things such as perhaps address, you know, number, phone number, really anything like that that is important to understand when you're receiving a referral inbound. And of course, the best thing being that there's no paper and it gets you off the phone. Okay, next slide. So here within the creating a referral process, so you'll see here that I have already selected my patient, and that's one of our test patients there, ADT4 test. And within that patient's summary record, down towards the bottom, you'll find the referrals indicator. And the referrals indicator is where you'll see the history of referrals for that particular patient. And when you want to create that patient referral, you simply click on the Create Patient Referral button. Next slide. So you being the referral source, you will be able to select any type of network association. So how I began our conversation talking about the medical neighborhood, that kind of makes the search somewhat smaller for everyone participating in that group. So many of them start with that network association. And then for the provider, for referring organizations, we normally will have a variety of providers that are more service level organizations than a true provider. So you'll be able to select that for your organization as well. And then you're going to click on Next, and we'll look at the next slide. So in the next slide, this is where we're going to pick that destination. So we're going to pick who we want to refer to. So as you'll see, there are some search criteria there. So you could search by specialty or service, or you can search by the organization. If you know the provider's name or the service of that mocked-up provider, you could also search in that manner as well. So once you select your organization and the corresponding provider or service, and you'll notice there's some red asterisks there, what that will do is that will then pull you into that organization to see both their inbound referral preferences and any reference documents that they may have available for you to pull down. And then you'll next select the reason, which will go to the next slide. So within the reason, you'll see that this is just a basic default of the system where you can type in your reason, any comments. You can also select ICD-9s and ICD-10s from the generated list. So anything that you need to do to help that referring partner learn more about your patient through this referral process. And then we're going to go to the next slide to look at the questions. Okay, so when we're looking at the questions here, these are those customized questions that has been created by this receiver of the referral. So what you'll see is a variety of questions, ones that this referring partner will need to understand before they could accept your referral. As you'll see, some of those have a red star, and again, those are required, so some information would need to be required within this customized questions section. And as you'll see, there are a variety of ways to collect information. So we have some checkbox groups there, some drop downs, and there's also text boxes. So next slide. So in our next slide here, what we're doing now is we're going to add attachments if we need to attach them to this referral. So if you are a provider organization, you could simply attach a care summary if it was relevant to this referral. Or you could upload a document. So uploading a document is very similar to how you would attach a file in email. So you're basically, when you click on the upload, it's going to browse to your file stores. So if maybe you had some office notes there, or perhaps the pre-diabetes screening, this would be a good thing to attach when sending through with your referral. And then on the next slide, we're going to go ahead and we're going to be looking through the referral, and this is the review and complete section. So you'll see there's some little pencils there besides some of the different sections. This would give you an opportunity to drill back into that portion of the referral if you need to adjust anything, and also if for some reason you missed a question, you can go back and fix that and then finish the referral. Okay, on the next slide. So the very last piece you're going to do, then when you're satisfied with all the information that you've filled out for the referral, you're going to click on the blue button at the bottom, and it's going to populate with your patient. So it's going to say refer with your patient. And once you click on refer, two things will happen. If this patient referral will populate your sent bucket, and they will also transmit over to the receiving end of that referral. Okay, next slide. So let's talk just a little bit about the monitoring piece. So in this first slide, we're looking at the sent referrals. So anything that you have sent outbound. And whenever the other side of the receiver of that referral makes any adjustments to that referral, such as scheduling, accepting, perhaps adding additional documents for you to review, you're going to be able to see that in real time from your My Recent Referrals. And you'll also notice that they are color-coded, so you'll see the green in the upper portion of that referral. That just lets you know it's new. And then if you look down through to Mickey Mouse, you'll see that Mickey Mouse is scheduled. And there's also a little talk bubble there. So another nice feature within a referral, as long as the referral is open, you can IM securely within that referral about that referral. So perhaps when you were originally sending the referral, maybe there was a certain piece of paperwork that you really needed to include, but it wasn't complete until after you submitted the referral. You're still able to attach to that referral in a secure manner. Likewise, perhaps maybe the patient had a change in a phone number, so you could simply communicate that within this referral. And again, it just keeps you from having to send faxes or from picking up the phone and trying to find the person that maybe you need to talk to about that referral. Okay, next slide. So in this slide, what we're looking at here is the received referrals. So you being a recipient of a referral, this is what your work list looks like when you work a referral. Okay. So we'll see here down under Spider-Man there, we show that the status is completed. So that way you know that you've already have completed the referral on that patient, and also the sender of this referral will be able to see that you have completed that referral. And again, you'll see the talk bubbles here as well. Again, just a little more information for you about that particular referral that, again, stays within that referral. And that concludes my portion, so I'd like to turn it over to Rich.
Thank you, Karen, so much. That was so complete. We'll let Rich do the presentation as it pertains to the DPP program specifically, and then open it up for questions. I think it's been valuable information that Karen provided. Rich, are you there?
Yes, I am. Thank you. So the referral that we're talking about is between Family Health Care of Northwest Ohio and Van Wert Community Hospital. They have a referral program, and they started to use our tool recently. We can go to the next slide. So we're going to show a couple of screenshots of how it looks to them. And just to start off with, so the referral is embedded in our community health record. So one advantage both practice in the hospital had is they did not currently use our community health record. So to use a referral process, they also got the full community health record application, which if you look down the left side of this screen, you'll see it has patient summary, encounters, results, medications, and documentations. So they not only get to use referrals if they do have a patient that they want to look up a lab or radiology test for, they can use our community health record and view that test. So that's certainly a benefit to the practice. They're using it for more than just referrals. They're using it for quite a bit. But for the referral process that we're talking about today, as Karen showed before, you select a provider, and Ann Dunn is a provider at Van Wert Community Hospital for the referral for the DPP program, diabetic program. So they select her on this list, and the inbound referral preference for Ann, just this little open dialogue section there, which can be modified per practice. All these can be changed and tailored to everybody's need in that little box. So it's just a little introductory, and you can put in there what you want. Next slide, please. So here's the first slide. When they are doing a new referral, they put in a reason and a comment. Next slide. And here's the questions that Ann Dunn at Van Wert Hospital likes everybody to complete when they do a referral for her. Right now, none of these are mandatory because we're just testing phase. We didn't want to make it too difficult where the practice could not accept or enter the information they needed or delay the referral process in any way. But if Ann finds it, say she needs number 2, the hemoglobin A1C, and people aren't putting it in, she can make that a mandatory field. So then they cannot continue past this page without filling that information in. But for now, it's not mandatory. And next slide, please. Here you can see what, on the new patient referral, the information that was entered. And it shows that the patient qualifies for the DPP. And it does give a little bit of information as far as that referral. And that's a summary page. Next slide. So this is how the the practice submitting the referral answered those questions that you saw earlier. So the patient is BMI is over 30 and A1C is in range, and certainly they put in range, but they could put in the actual values here if they wanted. Or as Karen mentioned, they could attach the actual A1C result. If they had a PDF of that result, they could attach that to this, and it's in a secured environment, so you can send that patient information back and forth. Some of these yes/no questions, they were left blank, and that's why there's no known value for those. But again, they could make them mandatory if they did want those filled in. Next slide. Okay, go ahead, Cathy. That pretty much concludes what they're doing so far. I did just want to report that it is new, so they're just trying it out and starting to refer patients to them. But as they get more people referring to them and more patients being sent, they can tweak this to meet their needs if there's any adjustments needed.
Right, and if you notice on Rich's slide here about the referrals, and as he said, some of these questions weren't answered, but the way this has been constructed tracks back to the CDC requirements in the ADA self-assessment form, so that you have basically all that information so you understand what the risk factors are. So I think that when Ann and Rich worked on constructing this, it really follows very nicely what the requirements are for the DPP, and also tracks back so you can really understand how the information flows, as we said, from the clinical setting into this referral setting. So, Rich, thanks for making it so complete. I think it looks real good. Let me just flip over. I'm going to have, and obviously here's both Karen and Rich's information if you have any questions, but we're going to go right into to see if someone has additional questions. I'm going to give it to Scott and let him.
All right. Pull up the questions here real quick. All right, our first question. Is the ADA diabetes assessment the only assessment tool we should be using?
There's actually more than one. The two most common ones are the ADA, and there's one that is AMA, very similar tool, but they just score it differently. And the ADA seems to be the one that's taking more predominance. And so I'd say use the ADA because the fields are going to cover everything that you would need to know.
Okay, a question about the referral tool. When you're creating a referral with an attachment, should the attachment in the case of the DPP be an A1C or lab work, or are there restrictions on the type of attachments, the type of files that can be attached to a referral?
Karen or Rich, you want to talk about the type of files, and then I can talk about what the type of attachment is.
Yes, so for the referral, there are no requirements on what you can attach. It just cannot exceed 20 megs, and that's a lot of space. So there's quite a bit of room there for you to attach.
Right.
So any file type, PDF, Excel, text, any attachment type of work?
Correct.
Yeah, and most of the times in this DPP referral, and Rich can talk about what Anna told them too, but it is the main attachment you're interested in is the lab result, but as Karen pointed out, you can also attach a summary of care document. So if that patient had been in and had an annual physical, or had been in for whatever reason, and you suspected that they were pre-diabetic, you ran the test, and then you got the A1C result, you can attach that, but you can also attach the summary of care document, which gives the receiving organization a little bit more information about that patient, if there's anything that would factor into the type of exercise or the type of nutrition that they could be expected to be eligible to receive as part of this program. Now, obviously, the DPP program itself, I'm sure will do screening, but it's also just another document that might help in getting more information together for that patient as they went into the prevention program. So, Rich, was there anything else that Ann had raised that that she likes to receive as far as information?
Well, the one point that Ann made, and other practice should see too, even if people forget to attach that A1C result, so this is part of our community health record, they can easily look up that result in the CHR. So they can see the actual lab value that was sent from the hospital or lab that performed that testing, and also any discharge summaries or history and physicals, things like that may have done upon discharge of the hospital. So when the patient is referred to them, they have treatment relationship with that patient and can see their results in the community health record.
Excellent point, Rich. You can always skin a cat in more than one way, and certainly the community health record gives the fuller picture, so that's good to know.
Next question is, how long does it take the recipient of a referral to be notified that a referral request has been submitted?
It's immediate. So as soon as you click that final button to send that referral, it will populate the received of the recipient side.
And that was the last question.
Okay. Let's just double check and see if there's anything else that came in.
Yep, that's it.
So just to expand on that, so once they receive that referral, they can instant message back and forth on that referral or do correspond back and forth until that referral is marked completed. And once it's marked completed, then nothing else will change. But so practice is a good idea to leave this open for a little while they're doing testing and things back and forth so they can continue that messaging.
Well, that was the last question. I would like to thank everyone for attending today's webinar. When you exit the webinar, just a reminder, you'll get a really short survey. Please take the time to complete that, and a recording of the webinar will be posted within the next few days to the CliniSync YouTube page.
Thanks so much to Karen and Rich, and to all of you. I hope you have a wonderful day, and we'll talk to you soon. Thanks. Bye.